Record this. Okay, I think we're good. All right, guys.
Are we ready?
Yep.
Okay. Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a local pediatrician, your host for today. I'm in the studio with Dr. Kelli Lupas from the Division of Behavioral Medicine. Let me start over. Is it lupus or lupa?
It's lupus.
Lupus.
No,
okay.
you're right.
Like the condition,
Lupus, yes.
but spelled A-S. Okay, sorry.
Yes.
As soon as I said, I'm like, oh, I better get this right on the first try.
No, it's okay.
Okay.
What a name for a doctor, right?
We're going to start over now.
Well, like Dr. Little in endocrinology always. That's just my favorite.
I did residency with Dr. Schatz
I
and
also-
Dr. Dye.
Yeah.
And they had a med school colleague named Dr. Payne. That was great.
I work with a Dr. Butts. Yeah.
Yeah.
God bless. With kids,
Lots
right?
of good names. All right, here we go. Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician and your host for today. I'm in the studio with Dr. Kelli Lupas from the Division of Behavioral Medicine and Clinical Psychology at Cincinnati Children's Hospital. Every day, I'm sure most community pediatricians see every single day, and that is attention deficit hyperactivity disorder, ADHD. First of all, welcome, Dr. Lupas. Thanks for joining us. So that our listeners can get to know you a little better, can you tell us a little bit about your background, your training, what brought you to Cincinnati, clinical interests, outside interests?
Thank you so much for having me. My name is Dr. Kelli Lupas. I'm an assistant professor of pediatrics and also the current clinical director of the Center for ADHD here at Cincinnati Children's. I'm an interesting path to this field because I actually have a background and my PhD is in school psychology and counseling psychology. I was a professor down at Florida International University for 3 years. Working in school psychology. I have a lot of passion for supporting students in the schools. But I came to Cincinnati because I have family in Ohio and wanted to be closer to them. And also because I think that our Center for ADHD at Cincinnati Children's is unique. We're one of the only specialty clinics in the entire country that offers almost every evidence-based intervention or service that exists for children with ADHD. So working here was a really unique opportunity and wanted to take advantage of that.
Wonderful. Well, I'm so glad to have you here. So ADHD is a very broad topic. You know, it touches on a lot of different things that we do as pediatricians, a lot of things that you do as a psychologist. To give our listeners kind of a common background, can you talk a little bit about both, you know, why ADHD happens, what we know about the pathophysiology, and a little bit about the incidence?
Yeah, so the prevalence of ADHD is high. ADHD is one of the most common mental health conditions that impacts children. Recent prevalence statistics from 2022 suggest 1 in every 9 children meet criteria for a diagnosis of ADHD. That's 10 to 12% of all school-aged children. We often tell people in any classroom of 20 kids, you're going to have at least 2 or 3 that have ADHD. So something we see a lot, and something that primary care physicians are very likely to experience and be one of the first places that parents go to when they have concerns. Schools and primary care offices are way more common than coming to me, actually. It's unlikely that most parents pick up the phone and call a specialty clinic from the first get-go.
Okay. As far as prevalence, males versus females, I mean, the 1 in 9 is the broad number, but is there a difference in prevalence between boys and girls?
Yes, there's usually like a 3 to 1 prevalence ratio where boys are more likely to have a diagnosis than girls. Some of that's changing. So as we start to understand ADHD in our diagnostic process, we've also started to realize that the presentation in girls looks a little different than it does in boys. Girls tend to struggle more with inattentive symptoms, and they tend to do a lot more what we might call masking at school, where they cover their symptoms, and so teachers don't notice it, but maybe parents do. So in general, boys are more likely to receive a diagnosis than girls, but that might be different in the next 10 years.
And do those different presentations influence age of diagnosis?
Yes, so that's a really good point. So girls are more likely to get diagnosed later in life, often in adolescence, when key developmental transitions occur. So this is actually really helpful to know about risk factors to be on the lookout for in primary care offices, because developmental transitions that kids go through that might spark, right, an emergence or sudden sort of high level of symptoms include the transition from elementary school to middle school and middle school to high school. Those key developmental transitions tend to involve a lot of changes to the environment and also the expectations we have for kids, like being more independent, being able to carry your materials and organize them and manage your time, tasks that would be very difficult for an individual with ADHD. So.
Yeah, and anecdotally, what I see in my office is a lot of even 3rd to 4th grade is a big jump. Certainly elementary school to middle school to high school, but even that, going from the early school years to kind of the middle part is a big jump.
Yeah, and there's key things that are happening there with requiring independence, new types of standardized testing. Homework often changes across those grades and things like that. And so all of those can be unique stressors that show you that executive function deficits have been present for a long time, but maybe never had the environment that brought them into light.
And use that term executive function, which is, I think, one of the key factors with ADHD. Can you talk about the different aspects of executive function?
Yeah, so executive function is a broad topic that I think with all of our TikTok channels, and I mean, everyone talks about it. It's something that most people have heard of. But executive function is a term for our ability to process information. The part of our brain most associated with executive function is the prefrontal cortex. That's the part right behind our forehead. That is the last part of our brain to develop for everybody. But in individuals with ADHD, that part is actually growing slower than it is for their typical peers. Executive functions include things like my ability to plan out a complex assignment, like a book report, and do pieces of it one by one. Executive function includes my ability to pump the brakes on making a choice about something and maybe choose something that would be, a little bit of a better choice, but takes a little bit of time to get to. Executive functions also help us filter out information. So if you think about a crowded room and I'm trying to figure out what information in this classroom is important, most of us would key in on the teacher. An individual with ADHD who has executive function difficulties might struggle to pick out key pieces of information and filter through all the other noise and things going on in any given scenario. So, yeah.
And I like the book report analogy. I use that all the time in my office. All the different steps along the way that you have to plan both organizationally, time management, all those kind of things, and that's definitely where those kids struggle. How does emotional regulation, emotional management factor in with executive function?
Well, that's such a good point. So when I talk to parents, I'm often using the metaphor of brake pedals in the brain. So I talk about, imagine that you're going down a really, really steep hill or a steep incline, and your car doesn't have brake pedals. So the side roads that you need to get off on are maybe parents saying something like, hey, you're getting really worked up. How about you take a deep breath? Or, hey, it's time to put the video games away. How about we start homework, right? Those are side roads. If you don't have brake pedals, you are not getting off on that side road. Your car is careening down that hill. And you may look at the side road as you go past and go, man, that's really important. I should get off on that side road, and not physically be able to do that. And that has a lot to do with what's going on neurologically for individuals with ADHD. But brake pedals, right? They apply to emotions too. So you need brake pedals in your brain in order to be like, whoa, I am really overreacting right now and I need to tone it down, or I need to step away or take a breath. When you don't have brake pedals, you might struggle to follow directions, you might struggle to switch tasks, but you also might struggle to control your feelings. And you might go from a 0 to 100 with your emotions in seconds, right? Where the rest of us would maybe have a couple barriers to getting to 100 before we do.
Yeah, and I think there's a lot of comorbidity between anxiety and ADHD, and we'll touch on that later. But that's, I think, a lot of times it gets confused. It's hard to tease out. What is emotional dysregulation due to ADHD and impulsivity? what is anxiety, what is ODD, what is all these things. So that's all that interplay is challenging, but it's
Yeah.
good to know that we can tell parents that that is part of the process.
Yeah, and I think something that we're discussing more and more often when we talk about ADHD is emotion dysregulation and how that goes hand in hand. Right now, it's not a core feature of the disorder. Not all kids struggle with it, but many, many do.
So if I'm in my office and I have a parent and family and child coming in, and the parent says, I think she has ADHD, where do you suggest that we start? What kind of questions should we ask?
I would even wind back just a little bit and say that the way that parents talk about ADHD sometimes, right, if they've thought about it a lot and maybe a teacher's come to them and used the words ADHD, they might be saying that term to you. But sometimes parents have these like code words or ways of describing things that, I mean, they make sense. This is how most of us talk about this in day-to-day life. But they might say something like, I'm really worried about her ability to finish work in class, or she always seems like an Energizer bunny, right? So also like just sorting through the terms that parents use and how they're describing some of these things. But let's say a parent brings up concerns about ADHD. The first thing that I really think is important is we need to look at what is like gold standard diagnosis process. If this is really a concern for us, we need to start to gather some information. Gold standard diagnosis involves about 4 different aspects. So the first part of a gold standard diagnosis is getting some rating scales. That could be ADHD-specific rating scales. It could also be like a broad behavioral screener, like the Strengths and Difficulties Questionnaire or the Child Behavior Checklist. Once you have some of those things, you're going to want to interview the parent. That's going to involve some specific follow-up on those rating scales. Third element is doing an observation of the child, which may be happening as part of all of these meetings that you're having and all these visits. And then the fourth thing that's really important is that we get some measure of how these symptoms are impacting this child's day-to-day functioning. We call that impairment. So a measure of impairment is embedded in certain ADHD rating scales. So for instance, the Vanderbilt has an impairment scale as part of it. And then there's other well-validated tools like the impairment rating scale that are very important to get as part of that information collection process.
Yeah. And I think the point you're making there is a good one, which is there's a lot of things to consider, a lot of things to bring in to that discussion. When we are talking to parents about ADHD, how important is it to gather things like family history, social history, the environment the child's living in? How do you approach those?
Yeah. So many things can look like ADHD. So we need to be careful when we're diagnosing it that we are doing our due diligence to the extent we can, right, to sort through some potential things that can cause worsening of symptoms or that can look like ADHD symptoms but not truly be ADHD. Family history, right? I think it's really important to establish, do any other members of your family have ADHD? If you have parents that have been diagnosed, if you have an aunt, uncle, siblings that have been diagnosed, well, we know ADHD is genetic. And so that really provides more support for there being a diagnosis in this child that's sitting in front of you that doesn't currently have a diagnosis. Other things to think about are any major like recent stressors that the family has been through. And I think broadly about stressors as we did a recent move. We moved school districts. One of the parents got really sick and we were in the hospital for an extended period of time and they weren't sure if we were going to come back home. Sometimes we don't always, right, think about those as traumatic, but in many cases they can be. And then that can cause, right, other types of difficulties with concentration. I might be thinking about that all the time. I might be hypervigilant and struggling in school because of that. So getting some information about recent stressors. And then also looking at things like school functioning and trying to ask some questions about, right, like what does this look like outside of your home? Because one of the key pieces of a diagnosis is that the symptoms are present across settings. Yeah.
And do you find a developmental history being helpful? So let's say we have a 10-year-old, asking about developmental milestones or preschool age, up until about that age.
Yeah. So understanding developmental history as far as when did this child crawl, walk, talk? How easy was it to get them potty trained? What's their sleep like? Sleep is huge with kids with ADHD. parents making comments like, we have never been able to get him to bed without laying with him for 2 hours, right? These would be some red flags I would be looking for in asking about developmental history. Other risk factors for ADHD include things like being very difficult to potty train and really struggling with regression and skills like that. Oftentimes less because the child doesn't know how to do things like that and more because they're on the go and they like doing other things and they don't want to be bothered with having to go to the bathroom. It's a motivation problem, right? But yeah, gathering some of those things can help you see whether there are risk factors for sure.
And if we're in our office and we have a high clinical suspicion for ADHD based on what the parents are telling us, we've not done any rating scales, would you say the Vanderbilt assessment is the gold standard, and what ages is that useful? That's
a great question. So the Vanderbilt is one of the gold standard ADHD rating scales. It's reliable and valid. It's been used for decades. The age range that it's normed on or that it was developed for is between 5 and 12 years old. So if you're using it outside of that range, you need to take some caution with the interpretation of the scores. There are other measures that measure ADHD that are more broad screeners, like the Child Behavior Checklist, that have an ADHD subscale that are created and developed for kids that range from 3 to 18. So if you're outside of the 5 to 12, you may want to switch to or do both. But the Vanderbilt is a great tool. Part of the advantage of the Vanderbilt I've found, that's what we use in the Center for ADHD. Part of the advantage of that is that there are scales for the ADHD symptoms. There's a scale for oppositional defiant disorder, a scale for conduct disorder, a screener for anxiety and depression, and an impairment rating scale. So you actually gather so many elements of different potential disorders or disabilities from one tool, and then that also relieves some of the paperwork filling burden on the parent.
And I'd tell parents it's 50 to 60 questions. You can do it in a few minutes.
Yeah, it doesn't take long.
Yeah. Now, one clinical situation that I struggle with is on a Vanderbilt. If you get very discrepant results from, two different parents, Generally speaking, dads seem to underscore more than moms, but that is not universally true, but that's been my experience. How do you handle that in the clinic? If mom is all 2s and 3s and dad just has a couple and lots of 1s?
Yeah. You also bring up a good point that we should be getting multiple informants. So part of gold standard diagnosis, which we haven't mentioned yet, but that is extremely important, is that you're getting both parent report and likely teacher or outside the home report. That's very important for knowing whether that criteria of symptoms being high across settings is met. When 2 reporters, mom, dad, 2 caregivers.
Or 2 different teachers
or
and different
teachers,
subjects.
When they are discrepant, it's very important to ask questions about the context in which those symptoms are being rated. So I might ask for 2 parents with different perspectives, what does mom do at home versus what does dad do? What kind of interactions and sort of tasks are each of them managing? If that comes back with one parent is managing all of the direction-giving tasks like getting ready for bed, bath time, doing homework, I might expect to see more difficulties with attention in those domains versus I play with them, I take them outside, I go to practice with them. Those tasks don't necessarily have to be gender-coded, but they can be. Oftentimes with dad engaging more in play or extracurricular tasks and mom's engaging more in homework, bath time, those types of tasks. So I'd want to know that. And the differential factor there being how many directions are you giving and how much does this kid inherently like the thing that they are being asked to do? And then usually if we feel some internal motivation, we're going to show fewer negative or disruptive behaviors. If it's a parent and teacher with very different perspectives, I'm starting to look at factors like what is the age of this child? What is the gender of this child? When I think about age, I think about how if we're already in a middle school or class switching scenario, then that teacher may only have eyes on this kid for 45 minutes. So I may be taking that rating with a little bit more of a grain of salt than I would the parent rating, who sees the child more often and has more of that history. Gender-wise, I'm also thinking about what we know about how girls present differently when they have ADHD, and the fact that if they're in class, they may be tamping down any hyperactive and impulsive behaviors. They may be struggling to focus, but it's hard to tell if someone's struggling to focus. That's kind of an internal process. And if you're finishing your work, most teachers aren't going to always pick up on it. And so trying to think through some of those things when I see discrepant ratings.
Okay. And then for older kids, 12 and older, are there any easily accessible or commonly used rating scales that you like to use?
I would say in the center, we're often still using the Vanderbilts. We're just also collecting really good report from parents and making sure that we get examples of those symptoms. And we're asking follow-up questions like, what does this look like? How long has it been going on? And trying to get some of that developmental history as far as oftentimes parents of teenagers tell me things like, you know what, I've been helping to organize their backpack since they were 5 years old, and we do these marathon work completion things on the weekend where I sit next to them for 8 hours on Sunday, and I think to myself, wow, you've been managing that inattentive behavior and disorganized behavior for a very, very long time. But maybe it just hasn't registered for you as a problem until now we're in middle school and we're managing 8 classes rather than 1. Trying to, so following up on rating scales, still might use the Vanderbilt, might use a broad screener like the Child Behavior Checklist that is validated for kids that are older than 12. And outside of that, I also typically collect a self-report from the adolescent themselves about how they feel about their own symptoms and impairment too.
Yeah, and in our practice, we see kids up through college, so, it's much more of that clinical interview, using either a Vanderbilt or questions from a Vanderbilt, but with a lot of clinical interview informing that. So sounds like you're doing similar.
Yeah. ADHD is genetic. It's something you're born with. Theoretically, those symptoms should be present from a young age. We need to establish that history. Do the symptoms always show up as severe or really impairing? No. Sometimes that only happens when we are in middle or high school and we're really tasked with being super independent. So keeping that in mind by trying to ask those follow-up questions is important.
Okay. So let's say that we have our conversation with the family, and we feel like they've met the criteria. We've gone through the Vanderbilt, we've gone through the interview, the observation in the room. We do feel that the ADHD is the primary diagnosis, or at least among the contributing factors. What do you recommend as next steps? Discussing management with families.
Yeah, so this is key. I'm so glad we're talking about it. There are 2 broad evidence-based interventions for the management of ADHD. The first is behavior management techniques, and the second is stimulant medication. I think here it's a really good opportunity to talk about the first one because I feel like there is a lot less training and support for primary care folks in providing that first one than there is training and support for providing medication management. So when we talk about behavior management, it can differ a little bit by age. So the first thing to mention is that for 3 to 5-year-olds, the American Association of Pediatrics actually recommends behavioral parent training as the first line step before medication management. So we should actually always be recommending supports like that for families of 3 to 5-year-olds that have behavioral concerns that line up with ADHD. Now, there's a huge access problem sometimes with recommending that. And so we're in this bind of being like, I know what the guidelines say, but I don't necessarily know how to get that into the hands of my parents. So I'm going to mention a couple of resources that are online and fully accessible for anybody that can be used by families that are good and evidence-based. So the first one is we have behavioral parent training courses that are online through organizations like Triple P. That stands for the Positive Parenting Program. Triple P has been around for decades. It has strong evidence supporting its impact on overall family functioning, child behavior, child ability to follow directions and do routines. That online course is free for families in Ohio thanks to an incredible grant program from our Developmental Disabilities Department. And it is low cost, like $65-ish for families outside of Ohio. In our area around Cincinnati Children's, that means Indiana and Kentucky. That's 8 sessions. It has very similar content to what we go over in our behavioral parent training groups in the Center for ADHD at Children's, including things like, right, how to help your kids follow routines, follow more directions, feel motivated to do the things that they need to do. It's not ADHD specific. It's about behavior generally, but an amazing place to start for parents and young kids.
What age is that targeted towards?
So there's 2 different courses. There's one for younger kids that goes up through age 12, so from like 3 to 12. And then there's actually one for teenagers too.
Great.
Yeah. So that's the first really great resource. The second one is that outside of behavioral parent training, which is really good for 3 to 12-year-old kids, right? There are also interventions for school-aged children like the daily report card. The daily report card's been around since the 1950s. That is a school home note. It is a way for parents and teachers to communicate daily about a child's goals, and then for parents to provide home-based rewards for children when they meet those goals. And goals could be things like follows directions with no more than 2 reminders, and we rate that in math class, reading class, etc. Daily report cards are a little bit tricky. They're something that school psychologists are well trained to do, but maybe not everybody, like even psychologists like myself or primary care physicians rarely get training in how to do interventions like that. But there are some really great resources for walking primary care physicians through how to do those. So the first one is something that we developed in the Center for ADHD called the MeHealth platform. That is an online platform. It's a subscription-based service that any primary care office can access. And we recently developed something in that platform called the Behavioral Tools feature that will walk a primary care physician and a parent and a teacher step by step through the development of this behavioral contract, this daily report card. Another really amazing online tool for daily report cards is something developed by our colleagues over at Ohio University's Center for Intervention Research in Schools, CIRS, Dr. Julie Owens and her team. It's called the DRCO, so Daily Report Card Online. That also has an online wizard that will walk you through all the steps. And then the last thing I'll mention is CHAD, which is our national ADHD organization, and they have a parent-to-parent course that parents can take for a low cost that also provides a lot of training. So there are resources out there.
Absolutely. And then, daily report card, I think that idea makes me think of school interventions. Part of our job as a pediatrician is advocating for our patients outside the office. So what sort of things can we do as a general pediatrician to help our patients in the school setting?
I'm so glad you're asking me this question because this is my passion area. So the first thing that I always try to let primary care physicians and medical residents know about the schools is that most schools have adopted what is called a multi-tiered system of support to address behavior in children. That actually comes from a medical triage model. So what that looks like in practice is a pyramid, where at the bottom of the pyramid we have foundational, or what we call Tier 1 behavioral supports, and those might include things like, does this teacher have a set of classroom rules? Do they give warnings about what time it is and when things are going to change in the classroom? Do they catch kids when they're doing the right thing and say things like, hey, great job turning that paper in just like I asked? Those types of supports, those Tier 1 supports, are typically things that most teachers are doing or trained to do from the get-go. We call them like classroom management strategies. For kids with ADHD, as we go up the pyramid, behavioral supports get more individualized or intense. So at Tier 2, we have supports that are typically linked to the daily report card type interventions, where we're providing specific goals for an individual child and rewards for meeting those goals. At the very top of the pyramid, we have much more individualized supports. We call those Tier 3 supports that are specific to maybe a school mental health professional coming into the classroom, observing the child with ADHD, and trying to figure out exactly why there is inattention, hyperactivity, or impulsivity occurring in certain scenarios. We sometimes call that a functional behavior assessment. And once we do one of those, then Tier 3 can also involve a behavioral intervention plan. Now, something I didn't mention when I described that pyramid was 504 plans and IEPs. Sometimes those types of plans live above Tier 3 or are even off the pyramid. Most schools want kids to go through all 3 tiers before making a referral to special education. So sometimes it's a misstep for us in primary care to tell a family that they should seek out a 504 or an IEP from the get-go. Schools often have lots of supports that they can provide well before an IEP or a 504 plan. And that's really important to advocate for on the behalf of the family.
Okay. And what method is usually useful for that advocacy?
Yeah, so I think in our practice, we're typically taking the approach of talking to the parents about each of those tiers and doing some psychoeducation around what that looks like, and then maybe giving resources for how they can start a daily report card.
Okay.
And we're talking a lot about those online resources that I just mentioned.
And if we've taken our families through all those different steps, referred them to the online trainings, we've talked to them about school interventions, when do we take the step to refer to a specialist such as the Center for ADHD? When does that kind of take that leap time?
So for assessment, that would probably be in cases where you have high ADHD symptoms and high other symptoms. We're very, very good at differential diagnosis, which really just means we're very good at trying to tease apart if it's ADHD or anxiety, if it's ADHD or trauma. And to be perfectly honest, a lot of those things often live on top of each other. So sometimes it's a little bit of a misstep to say that it's either this or that. Sometimes it's both. But we're good at making those decisions in the center. That's what a specialty clinic is good at. Other scenarios where you might want to refer to us for assessment purposes would include, high parent ratings, very, very low teacher ratings if there's discrepant ratings across informants. Other circumstances for treatment that are appropriate to refer to us, we provide behavioral parent training groups in the Center for ADHD that are in person for 3 to 5-year-olds and for 6 to 12-year-olds. Something really important that I'd like to say about our 3 to 5-year-old groups is that they do not require a definitive diagnosis of ADHD, that they are open to all parents of 3 to 5-year-olds that have behavioral concerns. We also provide 2 unique interventions as groups in the Center for ADHD that you might not be able to get elsewhere, including our academic success groups for middle schoolers and our academic success group for high schoolers. Those groups really focus on organizational skills and time management skills for those older adolescents.
And that's great. I've referred adolescents to that program, and they've always really appreciated it. How are we doing on time, by the way?
We're about 32 minutes in.
Okay.
So you guys are doing great.
Better than I thought. One of the more challenging diagnostic situations that I've found is diagnosing ADHD in kids with autism spectrum disorders or kids with other developmental disabilities or intellectual disabilities. Any pearls of wisdom that you can give as far as how to make that type of diagnosis?
Yeah, I would say first, I think the approach that we've taken with our colleagues here at Cincinnati Children's, so the Center for ADHD is a specialty clinic. We live within the Behavioral Medicine and Clinical Psychology Division. Our partner division or department, Developmental and Behavioral Pediatrics, are the colleagues that typically do evaluations for developmental disabilities and autism spectrum disorder and the types of things you just mentioned. In a primary care office, if a child already has one of those developmental disability diagnoses and you're now evaluating for ADHD, that's possible. Kids can often have both. So it's important to know that kids with autism spectrum disorder, there's a 40 to 60% chance they will also meet criteria for a diagnosis of ADHD. So definitely common scenario. The other thing is that the developmental and behavioral pediatric psychologists that do evaluations are very skilled at providing diagnoses of both ASD and ADHD. That's something that they do all the time. So that might be a good opportunity to refer to a evaluation by them.
Okay. And, at the beginning, you mentioned that, there's kind of 2 arms of treatment. There's behavioral management or behavioral interventions like you've, very detailed described, which I very much appreciate because that's what I need help with. Medications also play a role for some kids. How do you recommend we broach that topic with parents? Because we get a lot of hesitation from parents in a lot of cases.
Yes.
How do you describe that kind of those steps?
One of the main hats I wear is that I do diagnostic evaluations for ADHD, so I am frequently talking to parents about prescribe or manage medication, but it is one of the evidence-based treatments for ADHD, and I certainly want to provide psychoeducation about it. So it is a conversation I have a lot. I find that with parents, using and explaining the dopamine hypothesis of ADHD is one of the most effective tools to start a conversation about medication. I also find it's very helpful to know some of the literature on longitudinal studies of medication use and what studies like, for instance, the MTA, which is one of the largest ADHD research studies that has ever been done and has followed kids now from like the 1990s to today, and now they're like 35, and we have all this great data on how they've fared. Knowing what they say about medication use long term, because I think that that's where a lot of parents have these beliefs or feelings, right, about what medication is going to do. Mm-hmm. So when describing the dopamine hypothesis, I really start with, right, ADHD is genetic. We know that there are things in the brain that are different about individuals with ADHD. Also, I've switched to using the term individuals with ADHD because I've realized that a good half or more of the time, I'm sitting across from a parent that also has ADHD and trying to explain this to them without making it seem like their child's the only one that struggles with these things, right? So in individuals with ADHD, we have structural differences in the brain and functional differences. And those two terms really mean how the brain grows and develops and the kind of chemical signaling or blood flow that the brain is experiencing. So in talking about the structure, I really try to emphasize with parents in this kind of psychoeducation back and forth piece that the brain is growing, especially the prefrontal cortex, at a slightly slower rate than other kids. And I use this metaphor where I say, your child, maybe they are 10 years old, right? They can think and talk and reason like a 10-year-old, but they're gonna behave and have the attention more like a 7 or 8-year-old, like a 2 to 3 year delay. I feel like separating out the thinking from the behavior is really helpful for understanding the structural differences that parents really seem to, that's helpful for them. Mm-hmm. When I talk about the functional differences, I'm really trying to describe how in individuals with ADHD, there is not enough of the reward chemical dopamine. Dopamine is a feel-good chemical. Our brains release dopamine when good things happen to us. Theoretically, what should happen if I say something like, Tommy, I love that you put your shoes next to the door. My brain should release a little bit of dopamine. I should go, that felt good. I'm going to put my shoes by the door tomorrow. Unfortunately, in individuals with ADHD, dopamine is released when we say things like, great job putting your shoes by the door, but it's immediately sucked back up again. That reuptake is what causes the symptoms and impairment that we associate with ADHD. It also means that our kids are often dopamine hunting, and so things that give lots of dopamine, like video games, are going to be able to keep our attention way longer than other things, like homework, which gives 0 dopamine. So walking parents through that, and then talking about how behavioral interventions provide rewards because rewards give dopamine. So we are giving a low dopamine system the chemicals it needs in order to get through boring tasks like homework and chores. That's why we emphasize rewards. It's not because we're pushovers, it's because we are strategically doing something that is neurologically important for the brain. When I talk about stimulant medication, then that leads into, guess what stimulants do? They make dopamine. They help the system have more of the dopamine it needs, and they do it directly with that impact being so immediate. So I think framing it as, right, this is a biological thing, and the reason that those stimulant medications work is it's giving the system something it doesn't have naturally is helpful as a lead-in. Yeah. And
I've found that, having that kind of prefrontal cortex discussion early on and kind of when I'm talking about ADHD and then circling back and making that connection really does seem to help parents understand that, yes, there truly is something different that can benefit from medication therapy.
Yeah, I sometimes use like the metaphor like insulin for diabetes. And I also use that metaphor because I'm trying to help coach parents through the fact that ADHD is a chronic condition. 80% of children that are diagnosed with ADHD in childhood go on to have the symptoms and impairment that meet criteria for the diagnosis in adulthood. So managing a chronic condition means that we're going to need to have interventions in place for the long haul. It's not going to be 8 weeks of this intervention and then we're like cured, right? That's why we do training interventions as behavioral interventions, because I actually need to prepare you, the parent, right, to have the skills to use flexibly months and years down the road.
And the insulin for diabetes comparison, I often use albuterol for kids with asthma. That the stimulants don't make the kids smarter; they don't make them do better. It just helps them to unlock what they already have. The kid with albuterol, if a kid with asthma can't breathe, they can't do the things that they normally want to do. So if you can unlock that, they can play basketball, they can run with their friends. So
and we often say stimulants are really good at reducing symptoms. And when you're able to focus longer on things that you find boring, so a symptom of ADHD is sustaining your attention on tasks that require effort. When you're able to do that more, you're able to finish more homework. You're able to get better grades. And so there's a hope, right, that like by reducing symptoms, we're also going to impact this sort of functioning in the long run.
And then sometimes we'll come at situations where a family comes to us for a consultation for ADHD, and actually we don't think that that's what it is. Either the Vanderbilt assessments don't suggest it, the clinical history doesn't suggest it. What approaches would you recommend taking in that case, where the family's looking for that diagnosis, but you really don't think that that's what it is?
Yeah, that's so important, right? Like, let's do a good job making sure that we're giving the right treatments to the right kids and moving forward with diagnosis appropriately. Sometimes in those cases, I am actually still recommending some of these online resources, like the Triple P program that Triple P is not ADHD specific. It's about behavior generally. And I think that there's a lot of good psychoeducation in courses like that about what is developmentally normal for kids that's helpful for parents to hear. At a certain age, most 6-year-olds can't control their emotional responses to things. Their prefrontal cortex is really not developed yet. So their ability to stop crying or stop being upset about something that goes wrong for them, developmentally, right, just might not be there. That doesn't necessarily mean they have a disorder. That's just kids. So I do refer to those online programs sometimes for parents that have low symptoms. I also do a fair bit of coaching in session with parents about key foundational behavior management techniques. And so I'm often talking about how often are you paying attention to the things that your kid is doing right versus how much do you focus on the problems when they occur and engage in a lot of problem solving, especially for parents who are a little bit more anxious or I don't know, a lot of us are just concerned about our children's growth and development. We can get really, really hands-on when a problem occurs. Unfortunately, the message sometimes that sends to our kids is that they are a problem that needs to be solved. Kids can start to have really big dings to their self-esteem and also their behavior when that cycle starts to develop. So I talk about that. And I talk about things like giving effective directions, also a foundational key parenting skill, right? Good directions aren't shouted down hallways. They're usually one step for younger kids rather than multiple things like please go downstairs, grab your books, come back up here, give me one, and then go to the bathroom. And also, good directions are given once you have the child's attention, so really making sure you have eye contact. And good directions, you pause after you give them, and you don't repeat yourself over and over again. So maybe some coaching around skills like that.
Those are all the questions that I have.
Okay.
Was there anything else on that you noticed from the thought starters or other things that you wanted to hit?
This is our break.
This is our break.
Okay.
Yeah, sorry. Should have told you that, Kristen.
I can pick up what you're doing. Our audience will be like, what's a thought starter?
Or other just points that you
I
thought
know,
would
I've
be
said
helpful?
all of these things.
Okay.
Yeah, that's good.
Okay. Yeah, because I think, like I say, deep dive into medication, probably not for the scope of this podcast.
Yeah.
I think what you've told me is
And
fantastic.
we're at 43 minutes.
Okay, so I think we're
that's
ready to wrap up.
ample. Yep.
Good.
Cool.
All right. So, sorry, I'm just thinking about the things I got to hit my wrap up.
No CME.
So-
We're not doing CME.
Oh, okay, good.
Yes,
I'm glad
we
you
won't
said
do
that, 'cause that was on my
Just
list in my head.
Say thank you. The community practice
Support
support
tools
tool we
available
linked,
online.
as well as Corey and I've been noting like
Some of the resources.
Yep, we'll
Okay.
put all those
Yeah,
links
I
there.
can send you links and handouts and
And is
whatever
triple
you want.
P, is it PPP.org?
Just look up
or
triple P, the
Triple
phrase,
P?
the phrase
Okay.
triple P.
That's how it's referred to.
Mhm,
Perfect. Okay. Well, thank you, Dr. Lupas, for all of your time and expertise today. I think I've learned a lot. I'm sure our listeners have as well. For our listeners, today's discussion was guided by the Attention Deficit Hyperactivity Disorder Community Practice Support Tool that can be found on cincinnatichildrens.org. Also, a lot of the resources that Dr. Lupas has referred to will be linked in the show notes. So I hope everyone has a great rest of their day.
Thanks so much.
Sweet.
Perfect.
Very good.